Good afternoon, everybody. My name is Thomas Millett. I'm a PhD candidate in the Department of Health Promotion and Behavioral Sciences here at the UTHealth Houston School of Public Health. And I also work as a research assistant with the Institute for Implementation Science. And I'm happy to be introducing our last panel today, starting with Dr. Prajakta Adsul, who will be joining us virtually. Dr. Adsul is an assistant professor in the Department of Internal Medicine and a member of the Cancer Control and Population Sciences Research Program at the Comprehensive Cancer Center at the University of New Mexico. Most recently, she was nominated to serve as the inaugural director of the newly established Center for Advancing Dissemination and Implementation Science at UNM. And Dr. Adsul is a primary care physician by training and was a cancer prevention fellow with the implementation science team at the National Cancer Institute. As an implementation scientist, she uses community-based and participatory research approaches focused on health equity, often utilizing mixed methods that can help develop and test interventions and implementation strategies in pragmatic studies for cancer prevention and control, both nationally and globally. And Dr. Adsul, the stage is yours.
Thank you, Thomas. So nice to see you. And I'm so sorry that I cannot be with you all today, but I'm enjoying listening to the conference. In fact, a little bit more attentively at home than I would have in person. So I'm really enjoying. And Dr. Fernandez and Dr. Pujal, congratulations on what a wonderful day. Thank you for that kind introduction and the invitation to speak to you. I am going to be just like a dessert, short and sweet, and try to end your day with some learnings across this space that I've been very fortunate to occupy as a primary care physician, frustrated, wanting to do more social determinants of health, do more upstream factors that prevent disease, and then being frustrated with not having enough research informing my clinical practice. And then learning very much on the ground that you could have the best interventions and the best innovations, but if you didn't understand the multi-level context in which you were implementing, you wouldn't be able to actually impact change or have change happen in practice. So with the knowledge acquisition that happened at NCI in the implementation science program, I was very fortunate to be able to come to University of New Mexico, where on the land of the Pueblos, the Sandia and the Apache, I've been able to work in solidarity and work in learning from them and all of this work that we've been doing around implementation, research around cancer prevention and control. So as a global scientist, I've learned from my local communities, and as a local scientist, I've brought it back to my global communities, and bidirectional exchange of some of this information is where I really do see this equitable work coming in. So I'm happy to talk to you a little bit today about infusing equity, and I should have said global equity, global health equity into implementation science. So I'm coming to you today from Albuquerque, New Mexico. So hence you see this beautiful pathway in the mountains to Ghost Ranch, if any of you have visited here. And I wanted to just take a moment to reflect on the fact that this is something that I have shared in learning with Dr. Derek Griffith as well. In realizing and recognizing that health equity as a destination is something that none of us have really understood or lived in. We've never lived in a just world. So a little bit of this destination remains unfounded, ununderstood. And the pathway to achieving this space is a big one. It's an unpaved one, and we don't know what will work and what works, what won't work in this space, right? So I just want to acknowledge with humility that as we reflect on equity, that research might be a very small piece of the pie, and that we have to work in practice and we have to work in community to be able to go towards this destination that we all don't really critically understand yet. With that, I'm glad that I'm not the only one, and I get to stay here and stand here on the shoulders of giants that have worked in this field for decades before me, either using community-based participatory research, health disparities research. And truly, I think collectively, we've come to this understanding over the last few years that implementation science hasn't really explicitly always focused on equity, and that it might be an opportunity to include equity in research processes and our outcomes. So a few years ago, we were able to really talk about grounding implementation science and equity, especially in the context of cancer prevention and control research. So I was very excited to see the session earlier, really highlighting some of these principles that we spoke about in this piece. What has been new this year that we've been able to benefit from a larger group of us thinking is how do we think about global health equity through implementation science? And really, when we wrote this paper, we really took an approach of like deconstructing what we mean by implementation science from a Western, from a global North perspective, and really thinking about what would this mean if we were to think about it from a global health equity perspective. And the first thing that we focused on was global health partnerships, which is where so many of these power dynamics and so many of these challenges or opportunities both together arise equally. So how might global health partnerships reflect on decolonization principles, adopt an anti-racism practice, be grounded in indigenous values, and be guided by local culture and ethnic values? How might that robust partnership then understand intervention and implementation contexts so that we were able to then go towards an equity-focused global implementation science? And here we envisioned in deconstructing some of our language on implementation science, we really thought an equity-focused global implementation science would have partnerships-driven engagement to understand that intervention and implementation context. It would be guided by equity, be inclusive of theories, models, and frameworks. It would focus and select and adapt interventions for resource-limited settings and medically underserved populations. It would use these equity-promoting implementation strategies and always engage in an iterative participatory evaluation for the implementation efforts, as well as the equity outcomes that we are trying to achieve. Now, my primary area of research is cervical cancer screening, especially studying the implementation of it. But I'm grounded very much in my experiences as a Fogarty Fellow that I was able to take this innovative HPV DNA-based self-sampling strategy to some of the rural communities, rural and tribal communities in India. And here I was, bright-eyed, doe-eyed, wanting to change the world by implementing this new technology. After all, that's what research scientists did, right? And very quickly did I understand in my one-year fellowship that you could bring the biggest innovation to the field, but you cannot really integrate it into clinical practice or community practice till you understand all of the multi-level context and actually address them using specific implementation strategies. So I'm very grateful that that experience has always grounded me in what needs to be done from a provider perspective, from the healthcare setting perspective, and from the patient perspective. And I won't preach to the choir. You've heard amazing examples from Peru, from Iquitos, from other global spaces that have done this. So my learnings are shared with some of these excellent speakers you've already heard from. What I have been able to contribute from this experience and this grounding is a lot of work even in New Mexico, but also towards this larger global agenda of cervical cancer prevention. And in this global space, every diagnosed cervical cancer case could have been prevented really. And we have the robust evidence base that we need for effective interventions for vaccinations, screening, diagnosis, and treatment. Yet we continue to see those global inequities that Dr. Varone actually showed you guys. So I really believe that more efforts should now be directed at disseminating the evidence. So what we know works and generating the evidence needed for successful implementation. So how does it work, under what conditions, and for who, right? And I share the frustrations, Dr. Helen, with you, where we have these amazing guidelines now with the World Health Organization setting up these goals for us. But then how do we take these guidelines and actually implement them in the settings, right? So I want to acknowledge a lot of efforts by Dr. Gravitt here. Her impact is like a ripple in the ocean. Like there's a wide-ranging impact that Dr. Gravitt has had. And so some of these initial conversations really at the WHO level were with Dr. Brutet, Dr. Maribel Almonte, Dr. Patty Gravitt, who were really promoting this idea of shifting a research paradigm from developing and testing new interventions to focusing on adoption, implementation, and sustainability. Again, highlighted in several presentations, which will require that focus on readiness, focus on explicitly focusing on equity in reach and navigation through the care continuum, and this broad stakeholder engagement. So with that, I was very grateful to be able to contribute to this WHO implementation working group and team. And I thought this is a nice example for bringing to you all at the Global Implementation Science some of the work that we are doing more on a larger scale. And I have to acknowledge all of the folks that have helped with this, and you recognize some of the names from today's agenda itself. And grateful to WHO and NCI for the funding to be able to do this in a more systematic, rigorous way. And essentially in this working group, we identified several key implementation challenges for cervical cancer screening delivery. So if you look on the top row, it's the providers that deliver this care, ensuring eligible and at-risk individuals undergo screening, ensuring screen-positive individuals undergo diagnostics and treatment, so that retention to care, and improving acceptability for providers and the teams to implement those cervical cancer screening services. On the bottom row, you see some of these organizational challenges, right? From a national public healthcare system, how do we implement, how do we scale up, how do we sustain? And finally, how do we improve that global support towards implementation, scale up, and sustainability? So I'm hoping several of you in the cancer prevention space, as well as broadly, resonate with some of these key implementation challenges that really informed our approach to understanding some of the strategies to address these challenges, which are critical, but we don't have information in peer-reviewed literature about these strategies, right? So we have a lot of examples globally from people who have implemented cervical cancer screening programs, but most of that practical evidence or the practice-based understanding doesn't ever reach a research understanding. So this we thought, and really again acknowledging Dr. Gravitt's foresight here in saying, could we go back to these practitioners and actually start understanding what works, what doesn't work in their spaces? So one of the first failed attempts that we also did, though, was a Cochrane review to pull up some of that information on strategies and context in some of these settings. And we really, as you can imagine, in 3,000 words of an article, you don't get an opportunity to really go deep into the implementation stuff when you're reporting some of those positive outcomes, right? So we took an in-depth qualitative study with program managers, physicians, administrative and policymakers, researchers that were involved in the cervical cancer screening programs in these 6 WHO regions. And what we used innovatively, I think, over here was visual probing techniques. So I was joking with Dr. Gravitt earlier this morning, when you see a slide with diagrams, it's usually Dr. Gravitt. And so I just want to play this technique that together developed this in saying, how could we really go through the step-by-step complexity of the screening process and engage the individual that we were interviewing in understanding what did they try, what strategies did they try, how did it work, under what contextual conditions did these strategies work, and whether they would redo those strategies, so would they sustain those strategies, or whether they would also engage in scaling up those strategies. So we got this very detailed feedback from some of these practitioners to understand how the screening process was implemented in their context. And that has informed our understanding of some of these strategies that we've identified in implementing cervical cancer screening services. And so those 48 unique strategies were found to influence the key outcomes, as I stated, those implementation challenges in improving individual uptake, ensuring retention, improving provider acceptability, improving national healthcare system adoption and implementation, and then improving global support. So we identified 48 unique strategies across these 5 domains. We also asked each of the participants from their individual context to tell us a little bit more about the context in which they were implementing these programs and these strategies. And the context and implementation of complex interventions framework really supported this work, but we kept adding some additional domains, such as, what about the healthcare system in which you are implementing this? What about the status or the phase of implementation that you are in, to better understand this context as well? So this is huge. I don't want you to read all of this, but what I wanted to show you is for the first domain, just a snapshot of all the strategies that have been used anecdotally by some of this practice-based evidence, using the internet, using mass media, peer-to-peer networks, community health workers, religious or community leaders, using different locations, using self-collected samples or pre-planned, pre-scheduled days, and integrating cervical cancer screenings with other ongoing services. So you start to see what rich data we can gather from a practice-based perspective to then help inform what the next step or what the research should focus on if we are to build that evidence for implementation. One other aspect of this analysis has also been to take a regional approach. Since we had the most number of interviews from an African region and from the AMR region, we were able to look at the overall strategies used across the interviews, but also see what happens if you specify the region and how would those strategies get stratified according to the region in which they are implemented. So if you see in the AMR region, personal invitations and reminders just used by one person, but personal invitations and reminders in the AF region were like almost 3 times used by the interviews. Again, this is a lot of analysis and we are still sifting through some of that data and making sense of it. But where this has been really interesting to compare is with the existing list of strategies that we know from the ERIC project and that have been enhanced in some of the next iterations of this lists and this compilation. We did see of the 48 strategies, these overlapped with 52 of the 73 strategies that have been used in the space of health services, financial, and engagement-focused strategies. We also noted that there were some strategies that folks brought up in our interviews, such as patient navigation, improving care coordination, and conducting cost-effectiveness analyses that were mentioned by the participants, but were missing from the ERIC strategies. So we really see this as an opportunity for developing and iteratively building on the ERIC strategies to ensure that some of the practice-based evidence also informs our research. We think that this work really directly provides some of the methodological guidance on tracking and reporting implementation strategies. And most importantly, it is inclusive of the practice-based evidence in this space. We are hoping, as I said, to build on the ERIC compilation and contextualizing the form and functions of these strategies as they relate to cervical cancer screening programs. We are also thinking about the mechanisms in which these act. So Dr. Lewis's presentation was a really nice refresher to ensure that we can include that aspect into this space as well. What I am most excited about and most learning the most in this space is our work is really geared towards informing the future implementation guidance from WHO. So as WHO has launched these screening guidelines, how might this implementation guidance that we are producing together right now with WHO would support the ongoing systematic reviews, those living guidelines, and how would that actually help screening implementation and keep gathering some of that screening implementation data from some of these implementation initiatives. So along with some of the UNITAID and the CHAI and Expertise France supported projects together with the systematic reviews, we really hope for the first time to really push forward an implementation guidance along with the screening guidance that has been out front from WHO. So more to come on that. And I really appreciate the time and space to be able to talk to you all and with a lot of acknowledgements. Thank you.